This conference will now be recorded.
Sure,
Okay,
that's
great.
fine, Fiona.
Okay. Hello, everybody, and welcome to our today's webinar, which is being given by one of my colleagues and friends, Dr. Shelley Macaulay. So Shelley, as you will have seen from her bio, is a genetic counselor, a clinical genetic counselor. She runs the counseling training program at the University of Wits, which I have mentioned during previous study coordinator sessions. And I think we're really looking forward to hearing from a trained genetic counselor, I think with some more detail on exactly what genetic counselors actually do. As well as the kind of training that is required to be a qualified genetic counselor. Shelley is very passionate about educating healthcare professionals and increasing access to the genetic counseling service, which across Africa and in South Africa included in that, is something that is sorely lacking. And I think this is the start of something that will hopefully facilitate further conversations. And without much more, Shelley, I'll let you go ahead.
Thank you. Thank you very much, Fiona, and thanks to all of you for joining us today for this webinar. It's an honor to chat to you all, and thanks to the organizers for asking me to present. And I think just to say that, you know, this came about because I think there was a lot of confusion about who genetic counselors are and how they go about getting trained to be genetic counselors and what exactly genetic counselors do. So I'm hoping that today I can educate you all and clarify some misconceptions and answer any questions you may have about the field of genetic counseling and the training to become a genetic counselor. So the title of my talk is Genetic Counselling as a Profession, Training and Scope of Practice. And as Fiona said, I am a clinical genetic counsellor myself. I run the Genetic Counselling Master's Degree Program at the University of the Witwatersrand in South Africa. And I work at the National Health Laboratory Service as well as a genetic counselor and as the genetic counselling manager. Okay, so starting off with the history of genetic counselling. My slides are not moving. Sorry, let's just see if they can, there we go. So genetic counselling, the term genetic counselling has actually been around for a very long time. There was an American biologist and geneticist called Dr. Sheldon Reed who actually coined the term genetic counselling. So he practiced genetic counselling, being in the field of medical genetics, and he said genetic counselling really involved three components. Firstly, an individual needed to have knowledge of human genetics. They needed to have respect for sensitivities, attitudes, and reactions of patients, and they needed to have the ability to teach and provide genetic information to the full extent known. So it wasn't until 20 years later, after the term was coined, that genetic counselling actually became an independent profession. The very first graduate program was started in 1969 in America at the Sarah Lawrence College in New York. So if you think about it, genetic counselling is a fairly young profession. It's only 50 years old. So often when I say to people I'm a genetic counsellor, you usually get a what? A response to this is quite uncommon. People don't really know what a genetic counsellor is, what do we do, and so forth. And then a lot of people ask, so are you a psychologist, or are you a medical doctor, or are you a scientist that works in the lab? And the answer is no to all of the above. So then what is a genetic counsellor, and who is a genetic counsellor rather? Genetic counsellor is an allied healthcare professional. Genetic counsellors are trained at the master's degree level. It's a professional master's degree all around the world. And these individuals have specialised education in medical genetics and counselling. So with that in mind, the actual process of genetic counselling is a combination of science, medicine, and communication. And genetic counsellors need to be familiar with medical genetics, with the science behind genetics, and have the ability to communicate complex concepts to patients. So these are the three components that really make up the field of genetic counselling. The definition that's used around the world, this is the definition that all genetic counselling units use, is genetic counselling is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. So in summary, that is what genetic counsellors do. And the process integrates three components. Firstly, the interpretation of family and medical histories to assess the chance of disease occurrence or reoccurrence. So one of the first steps we will always do in a genetic counselling consultation is draw up the family pedigree. We will look to see what genetic conditions are in the family, what's the pattern of inheritance that the condition is following, and also to ask lots of questions about medical histories and so forth. Secondly, education about inheritance, testing, management, prevention, resources, and research. So educating patients on how did this genetic condition occur? What's the pattern of inheritance? What's the chance of this happening again? Who else in the family is at risk? Who should have testing? And what could we do to prevent another child being born with this genetic condition, for example? And we're also involved in putting patients in touch with support groups and research projects. So sometimes there isn't genetic testing available for a particular condition, but there is a lot of research that's happening. And so it's our role to make sure we're familiar with all the different research projects on genetic conditions so that patients have access to that. And lastly, a very important component obviously is the counselling. So genetic counselling involves psychosocial counselling to promote informed choices and adaptation to the risk or condition. So we need to think about, having a diagnosis of a genetic condition can be really traumatic for a family. And also, it doesn't necessarily just affect the one person. Genetic conditions tend to affect the family as a whole. So one needs to be sensitive towards this and obviously have the skills to be able to counsel patients and families about the genetic condition and also to help them come up with informed decisions and informed choices that are right for them. So the type of approach that we take is a person-centered approach to genetic counselling. So if any of you have psychology as a background or have read up about the different psychological theories, the one that genetic counselling is built on is Carl Rogers' theory. And Carl Rogers' theory was person-centered, and the purpose of this type of counselling is to empower the patient, to value the patient's belief systems, so to respect what they believe and the decisions they make, and ultimately you want to strive to help the patient understand what's going on, taking in mind the patient's own experiences as well. We employ a non-directive approach, which is quite different to other fields of medicine. So patients are often used to being told what to do, especially when they're sick. You must take this medicine or you need to have this operation. And so it can be quite a challenge when patients come for genetic counselling. It's a very different approach. We are non-directive. We don't tell them what choices to make or what they must do. And rather our role is to present them with options. So these are your options. For example, in a prenatal case with severe fetal abnormalities, the genetic counselor's role is not to say you must continue with the pregnancy or you mustn't, but to rather provide the patient with options and get them to think about what the right decision would be for them. Another component of genetic counselling is us being non-judgmental. So we accept patients and their decisions and accept that what decisions they make are right for them. And that ties in with the non-directiveness as well. And then to have respect for patient autonomy. So again, this is also built into the Carl Rogers' theory, where you view your patient as an individual who is able to make their own decisions that are right for him or her, and respect that their decisions that they make are those that are most appropriate. So that's our approach. In addition to that, there are three attitudes that a genetic counsellor needs to employ to be in this field. The one is to have unconditional positive regard for his or her patients. So that's to view the patient just the way they are and to accept them for that. Secondly, to be genuine. So the genetic counsellor you see now is the genetic counsellor I am when I'm with patients and I'm not with patients. So to be a true person. And to have empathy. And empathy really differs from sympathy. Sympathy is feeling sorry for someone. Empathy is really putting yourself in their shoes and thinking about how this might affect them or how they may be perceiving this information. So those are three key areas of genetic counselling that we train individuals on and we adopt as our strategy when we see patients. Okay, so thinking about where we practice and what the scope of practice is. So Fiona mentioned earlier that I'm a clinical genetic counsellor, so I see patients in the clinical setting. And there are various clinical settings where genetic counsellors are needed and where genetic counsellors see patients. I'm just going to talk you through a few of them. So one of the areas is prenatal, preconception genetic counselling, dealing with pregnant women or couples that have had pregnancies where there have been abnormalities detected, or women who are of advanced maternal age, they have a higher chance of having a baby with a chromosome abnormality. Or couples who've had multiple miscarriages. Those are some of the examples that would fall under the prenatal preconception area. Then, of course, there's pediatrics. We see a lot of pediatric cases. In fact, in our clinics, our cases are predominantly pediatric. So those are children born with genetic conditions like Down syndrome or trisomy 18, hemophilia, cystic fibrosis, and so forth. And when a diagnosis is made, referring the parents to us to explain what is this genetic condition, how did it happen, what does it mean for the child, what management do we need to put in place, what's the chance of this happening again if the couple were to have another child. Another area is cancer. So about 10% of all cancers are actually inherited. And so our role is to identify high-risk families from those that probably just have sporadic cancers. We see a lot of cases in our clinics in Johannesburg related to inherited cancer syndromes. And then there's also cardiology. This is an area that's, there's a lot more knowledge around it now. Some clinics are more focused on cardiology than others, but there are a lot of inherited cardiomyopathies, cardiology syndromes, and that's important for those families to receive genetic counselling. Neurology is another area. So, for example, Huntington's disease. We see a lot of patients with Huntington's disease or spinal cerebellar ataxia that involves obviously the central nervous system. And then the other area that's developing is the assisted reproductive technology or infertility area. So for families where there is a known genetic condition, obviously there are prenatal options that are available to these couples. So we would talk them through undergoing prenatal testing, but there's also something called pre-implantation genetic diagnosis, PGD, whereby couples who are carriers of a particular genetic condition, or if one of the couple has a genetic condition themselves and they don't want to pass it on, can undergo PGD. So basically it's in vitro fertilization where we test the embryos to check if they've got the genetic condition or not, and only those that do not have the genetic condition are then implanted. So these are the kind of areas that clinical genetic counsellors work in. And I've just given you a few examples of some of the patients we see. This slide also refers to some of the other examples. We've spoken about pregnant women who are of advanced maternal age. We also see in the prenatal setting teratogen exposure, so pregnant women who have been exposed to a particular, perhaps they're on anti-epileptic medication. We know that that is teratogenic to a pregnancy, so not necessarily true genetic, but obviously has an influence on the developing fetus. So we'll see those kind of cases as well. I've spoken to you about pregnant women with fetal abnormalities on ultrasound. Obviously families where there's a known genetic condition, so people will come to us and say, I had an uncle with Huntington's disease, or there's a BRCA mutation that causes inherited breast cancer in my family. What are my risks? And then another one I've just mentioned, there are couples from high-risk ethnic groups. So we know that certain genetic conditions are more common among certain population groups. So for example, the Ashkenazi Jewish population, they have a higher percentage of autosomal recessive conditions than other populations. And so sometimes high-risk couples come to us and say, what screening should we do before we fall pregnant? So those are just some of the examples that we see in the clinical setting. Okay, so what does a typical genetic counselling consultation entail? So firstly, what we're interested in is gathering information from the patients. I said to you earlier, the first step we always do is drawing up the family pedigree. So who's got what in the family, what's the pattern of inheritance that we're picking up? So we ask a lot of questions. What are the patients hoping for from the consultation? What's the family history? What's the medical history? We gather a lot of information to help us then align how we present the information and also what we present. What diagnosis are we dealing with? Obtaining reports, special investigations. Do we know for sure that this is a particular genetic condition or not? I must also just point out to you that genetic counsellors tend to see families and patients where a diagnosis is known. So they'll come to us when a child's been diagnosed with haemophilia or with cystic fibrosis. We also see a lot of families who are concerned of their family history of cancer, and that's our role to then say, we think this is genetic or we don't. Medical geneticists, who are doctors trained in genetics, they tend to see children or individuals where a diagnosis is not yet known. So perhaps someone has unusual features, we call it dysmorphic features or developmental delay, and no one really knows what's going on. One of our medical doctors will then see that child to try and determine a diagnosis. So genetic counsellors don't diagnose. We consult with patients where diagnosis is known or where there's a suspicion that there's, for example, an inherited cancer syndrome in a family. Okay. And then obviously we do a risk assessment. What is the chance of this happening again? How did this happen? What are the options available to patients? Information giving, so explaining to the family or to the patient, what is this condition? How did it happen? What management do we need to put in place? What other investigations should we do? What genetic testing options can we consider? That's the role of the genetic counsellor. And as I said to you, our role is to facilitate decision making. We don't make the decisions for the patients. We rather help them reach a decision that's right for them. And we follow the non-directive, non-judgmental attitude that I spoke to you about. And then obviously we provide ongoing patient support. So we do referrals, we facilitate testing if testing is needed, and then we follow up and manage appropriately. And this whole time throughout the genetic counselling process, there's obviously the psychosocial support. So bearing in mind the effect that a diagnosis might have on an individual from a psychological perspective. So that's a typical genetic counselling consultation. What I want to talk to you now about is, the way genetic counselling is actually evolving and moving as we're moving in this genomic era that we speak of. So in the genomic era, there's been a lot of research about precision medicine. I know many of you have been involved in a lot of the H3Africa studies that are looking at complex diseases. So trying to ultimately understand one's risks towards complex diseases and how can we reduce morbidity by understanding that better. And precision medicine, obviously trying to design medicine according to one's genetic makeup. So it's not a one size fits all, it's rather tailored specifically to your genetic makeup. And with these advancements comes this whole process of genetic counselling actually evolving and taking on other roles. So there's been a lot of research, genetic counsellors being viewed as an asset in the era of precision medicine, how technology is now impacting on the practice of genetic counselling and how we've had to adapt and think about new things, and then how the profession is growing because of this new genomic era. So if we think about the genomic era, there are now newer technologies available. So next generation sequencing, for example, is now available. And with this comes a reduction in the cost of genetic testing and also the ability of us to do what we call multi-gene panels. So in the past, if we suspected a patient had, for example, an inherited breast cancer syndrome, all we used to be able to do was test the BRCA1 and the BRCA2 gene. But now we can do panels. So instead of just testing for 2 genes, we can test for 30 genes that are all inherited with, all associated with breast cancer. So there's this reduction of cost, but there's increased accessibility as well. And almost anyone can now request a genetic test. There's tests available online. Patients themselves can order them. These direct-to-consumer tests, ancestry testing, finding out where you came from. And then, as I spoke about earlier, this whole move to precision medicine. So whilst this is all positive and we're moving with these wonderful advancements in technology, it also means that we have the ability to create and generate rather a huge amount of genetic data. And this speaks to a lot of the projects that you guys are all involved in. So, with multi-gene panels, you're looking at between 400 and 400 genes. But if you're doing exome sequencing, you're looking at 22,000 genes. And if you're doing genome sequencing, you're looking at 22,000 genes plus. This is a huge amount of genetic data. And as I said, so we're now moving away from traditional genetic testing approaches, moving away from single gene testing and chromosome, doing karyotypes, and rather moving towards this next generation technology. And these are some of the buzzwords that I'm sure many of you have heard: whole genome sequencing, whole exome sequencing, and a lot of the genetic projects that you're involved with will obviously have these methods attached to them. So, as I said, this is all wonderful and an excellent advancement, but it does come with challenges. And the challenges are, what do we do about changes in DNA that we don't yet understand? So when researchers or scientists find changes in DNA and we're not quite sure what they are, how do you feed that back to a patient in a meaningful manner? How do you determine what's pathogenic, so disease-causing, versus what is just normal genetic variation? And there's this issue of these VUSs, variants of uncertain significance. So where we find changes in the DNA, but we don't really know if it's pathogenic or we don't really know if it's benign, there isn't enough information yet. And this is tricky for us as scientists and researchers, but imagine how it is for patients as well. The other issue is that most reference sequences come from Caucasian populations. And so this poses a huge problem for all of us on the African continent because African populations are under-researched. So if you find a change in the DNA of an African patient, for example, can you really say that it's pathogenic, or is it just normal genetic variation? It's difficult to know when your reference sequences come from a different population. So there are a lot of challenges associated with next generation sequencing in this genomic era. Some of the things are, what might you find? What are you going to find? You're looking for one thing, but you're actually testing another 10 genes or 400 genes, you might find something else. Have patients or participants received informed consent, or rather provided informed consent? Do they know what could be found or what might not be found? Is the patient prepared for an incidental finding? So you might set out to test, for example, you're looking at genes involved in blood pressure, but you happen to discover that the patient has a monogenic condition that causes an inherited cancer syndrome. Does the patient know that there's a chance that there's an incidental finding? And the other thing is, what is appropriate to feed back to patients and participants and what is not? So how do you make that judgment call? So with this in mind, really, you could be opening up a whole can of worms by doing all this different testing. So that being said, genetic counselors are really essential people in this genomic era. And that's because we possess a core skill set that allows us the ability to interpret data and translate the data into clinically meaningful information for patients. Genetic counselors have the ability to explain genetic technologies to patients, the ability to communicate uncertainty to patients, and they also have the ability to know how much and which information to share with patients, which is often quite tricky. How much do you give them? How do you explain it to them? You also don't want the wrong message to come across. So, for example, someone who has high-risk alleles for hypertension, or rather low-risk alleles, you don't want the wrong message to go across that they don't need to worry about their diet and their weight because they're at low risk of hypertension. We know that the environmental factors are as important. And so this is where genetic counselors can assist. There's been a lot of research about the importance of genetic counselling in genome-wide sequencing, which many of these projects entail. And just some of the comments that have come up from these research projects are, they've shown that patients really have a better understanding of the results and improved decision-making when they receive pre- and or post-test genetic counselling. So it's shown to be really beneficial. And the other thing is, some patients and physicians believe or think of diagnoses as black or white. But actually, diagnoses are not always black or white. There's this grey zone, variants of uncertain significance, incidental findings, for example. And that's where genetic counselling is really valuable. So keeping this in mind with this movement with next generation sequencing, precision medicine, and so forth, genetic counselors' scope of practice is also changing. Traditionally, it was always in the clinical domain, and slowly it's moving out. So, for example, genetic laboratories are now employing genetic counselors to help with result interpretation, because we have the skill set to be able to put together the clinical information and the laboratory-based genetic information and see how they fit. So genetic counselors are being employed to help report on genetic test results, help to determine whether variants are pathogenic or not, or variants of uncertain significance, and then also to be able to communicate that information to patients and to referring clinicians. The other area genetic counselors are in is research. So many genetic research projects have never employed genetic counselors before because scientists and researchers have run them. But now people are realizing that actually, how do we convey these results to participants and to patients? And that's where genetic counselors can assist. Some genetic counselors are purely in education and academia, so just run courses such as myself, but I do clinical work as well. And the other area that we're starting to see very slowly in our country, but certainly a lot in America, is this direct-to-consumer testing. So patients being able to ask for their own genetic tests and then not being able to understand the results. So we've had a few of those coming through our clinic where patients phone us and say, I don't understand what I've just been tested for. And so that also goes to show that pre-test genetic counselling is important. But obviously with these direct-to-consumer tests, they don't get that. I want to just direct you to two papers that are really interesting if you wanted to do any further reading. Both of them I was fortunate enough to be involved with. The one is a commentary about genetic counselling globally, where are we now? And this was published in 2018. And the other one is about the global state of the genetic counselling profession. And this was written by a whole lot of course directors and senior genetic counsellors from around the world. And I'm going to show you a few of the results from one of the papers. So the first one is we looked at how many countries around the world actually offer formal genetic counselling programs, so master's degree programs. And this table represents all of those. There's 27 countries around the world that offer genetic counselling as a master's degree. And obviously of interest to us is Africa. And you can see that the only country in Africa that has a formal genetic counselling program is South Africa. So the two universities in South Africa are the University of the Witwatersrand and the University of Cape Town. Wits University, which is my university, started genetic counselling in 1989, and Cape Town UCT followed a few years later, well in 2004. Both universities offer the degree. It's a Master of Science in Medicine, an MSc Med in genetic counselling, and it's a professional degree. And both units only take around a maximum of 4 students. We offer the course every 2 years. Cape Town offers the course every year. So in terms of the genetic counselling training in South Africa, just to give you a bit of background, individuals tend to enter the program with an honours degree in an appropriate discipline. Most individuals come in with a science honours, a BSc honours in one of the life sciences, but we have had individuals come in from psychology and from nursing as well. And they need to have achieved 65% or more for their honours degree in order to be considered for the masters. The MSc Med in genetic counselling is a 2-year degree at both universities, and it involves coursework and research and in-clinic training. So they're formal lectures. The students also do a research component, and obviously a huge component of this degree is being in clinic and observing genetic counsellors and slowly starting to do genetic counselling themselves. In addition, in our country, in order for us to practice, we have to be registered with the Health Professions Council of South Africa. So that's a 2-year internship program. The first year of the internship overlaps with the second year of the degree. So individuals then do 1 year post-degree of internship. And that internship involves them putting together a portfolio of evidence, which is then examined by South African genetic counsellors around the country. And then they gain registration with the HPCSA and then can legally practice as independent genetic counsellors. These are the modules that are covered. So we do a large component of medical genetics, so understanding the the medical background to the different genetic conditions. The principles of genetic counselling is a lot about the counselling skills, the psychology, practices of genetic counselling, the practical aspect, and as I spoke to you about the research report, that's another component that's very important. So if we look at what's happening around the world with genetic counselling, this map shows you where genetic counsellors are located, and you can see most genetic counsellors around the world are actually based in America. They've got over 5,000 genetic counsellors, but in total we've got around 7,000 genetic counsellors globally. So it's growing. You can see in Africa, which is just focused on South Africa, we've got less than 50. So we are quite far behind everyone else, but it's slowly growing, and we need to think about expanding this beyond just South Africa. So what are the recommendations per million population? Well, the Royal College of Physicians and the Association of Genetic Nurses and Counsellors in England say that we should have 10 genetic counsellors per million population. That's actually the recommendation around the world. And if you look at the genetic counsellors per million population here, you can see the only two areas that are doing really well are Cuba and the USA, where they've got well beyond 10 per million. Israel's not far behind them. And then again, if you look down at South Africa, we're quite far behind what is expected and recommended. But then again, also South Africa is the only African country on this graph. So that's something that we need to think about. Genetic counselling in America was voted as the #1 job last year. And there's a huge demand for genetic counsellors. There's a big push in America for precision medicine. They've got lots of laboratories. And yes, they're a developed country. And, you know, we are far behind, but this is how we should be moving, and the rest of the world should be moving as well. That picture on the right-hand side that you can see was taken by Professor Kathy Wickland, who's one of my colleagues in America. And that board was in her genetic counselling unit in Texas. And those jobs are just genetic counselling jobs. So you can see there's a massive demand in America for genetic counsellors. Unfortunately, our situation in South Africa is not the same, and we do struggle with shortages of posts. But as things are moving and technology is improving, we really need to think about the role and importance of genetic counsellors. So do you have what it takes to be a genetic counsellor? If any of you are thinking about genetic counselling or know someone who is, individuals need to have critical thinking skills. They need to have a really good understanding of the science involved in genetic disease. They need to be able to explain very complex concepts in a meaningful way to patients. They need to have a desire to be a lifelong learner, because genetics is evolving and changing every single day. They need to have good interpersonal skills. You have to love working with people and patients, because that's the work we do most of the time. And obviously, you need to be empathic and patient in nature. There's a very nice online talk, or online course rather, that's free, that I wanted to direct your attention to. It's been run by the Wellcome Genome Campus, and you can reach it on this URL. I was involved with reviewing the course, and I'm actually part of one of the course components. But it's a nice overview for people who are not genetic counsellors to really understand what is genetic counselling. What kind of cases do people see? And there's a bit about genetic counselling all around the world. So the course coordinators actually interview genetic counsellors from all around the world to get their different aspects. So if any of you are interested in finding out a little bit more, I would encourage you to go and have a look at this online course. And as I say, it's free. So it's something nice to consider. Okay, so just wrapping up, what are the take-home messages I wanted to convey to you all today? Firstly, I think it's really important to know, because I think there was a lot of misconception about genetic counselling. Some people thought that they were medical doctors or physicians. Genetic counselling is a profession in its own right. So genetic counselling is a professional master's degree. Genetic counsellors are not medical doctors. They are highly skilled allied healthcare professionals who are equipped to handle the complexities of genetic disease, be it monogenic disorders or complex disorders. They've got the skills to be able to interpret that and to convey that to patients in a meaningful manner. Genetic counsellors have a really important role in supporting and educating healthcare professionals and patients, but also researchers, and advising on testing options and how to interpret genetic testing results. And lastly, genetic counselling forms an integral component of the management and care of patients and families with genetic conditions. So if you had a patient who had a cardiac defect, you're always going to involve a cardiologist. So if you've got a patient who has a genetic condition, you should always involve a genetic counsellor. So thank you everyone for listening. That was my talk about genetic counselling. I hope I've enlightened you, and I'm very happy to take any questions you have.
Great. Thank you so much, Shelley. So just to mention maybe very briefly that I have worked with Shelley in various settings for the last few years, and I think you'll have gotten a little taste in the last half an hour or so how incredible she is. She really does care tremendously about her patients as well as the students and trainees that she has under her care, and in every sense tries to go above and beyond. And hopefully she has communicated some of the passion that she has around genetic counselling. And I'm hoping there'll be some questions and some discussions. She's left us some time to do that. So can I just hand over maybe to Rolanda to moderate the questions?
Thanks, Fiona.
Sure. People are welcome to chat or type in the chat box for the questions, or you can just unmute yourself and ask away. So Catherine says it's very interesting, just wondering how often, let me just bring that up again. How often you need to explain family and inheritance and what you use to explain this to patients. I'm working with how to collect patient pedigree data, so just interested.
Sorry, Rolanda, can you read that again? I can't see that message from Catherine.
Sure. So she says, thank you, very interesting. Just wondering how often you need to explain family inheritance and what you use to explain this to patients. I'm working with how to collect patient pedigree data, so just interested.
Okay, so Catherine, are you saying you're collecting patient pedigree data?
Yeah, she is.
Okay. So in terms of explaining inheritance, I mean, we have a variety. I think the other important thing is to be flexible, because patients and participants, for example, come from various educational backgrounds, and many of them have never actually heard of genetics before. In many of our African languages, for example, there are no words for genes and chromosomes. And so we have to be flexible regarding how we actually convey the information of inheritance. That we use the pedigrees to explain to patients. Often it's quite visual, and patients can follow when you draw up the pedigree how something is tracking in a family. We have a variety of tools that we use, carrier types that we take to clinic with us, pictures that we draw to explain the different patterns of inheritance, dominant and recessive. There isn't a particular one way of doing it. I think you need to take into consideration your patient's background, their level of education, and also what condition you're dealing with. I'm not sure if that answers your question. I can't be more specific, but let me know if there's anything further.
Thanks, Shelley. So Karen Kenny has also asked the question in the chat box, asking whether medical doctors in other parts of Africa who are familiar with genetic counselling may also formally counsel patients.
So yes, I think I'm speaking specifically of genetic counsellors, but that's not saying that individuals with an understanding of genetics can't counsel patients. So in Africa, where you have no genetic counsellors other than in South Africa, of course medical doctors can provide genetic counselling. Nurses can provide genetic counselling. They can't call themselves genetic counsellors. You can only call yourself a genetic counsellor if you have the actual qualification. But that's not to say that other people can't counsel patients. If they've got the knowledge and they have the skills to do it, absolutely. And I think we need to be realistic. There are not enough genetic counselors in the world, let alone in Africa, to say that only genetic counselors can explain genetic concepts to patients. So absolutely, yes, medical doctors, nurses, allied healthcare professionals, as long as they have an understanding of the genetics, of course they can explain that to patients.
And Tembela just says, thank you very much for an informative presentation.
It's my pleasure.
Are there any other questions? Oh, so Tembula is now asking a question in the chat box.
My question is, are you compelled to inform patients? Is that what you said, Temba?
Compelled to inform, yeah, probably.
Inform patients about what?
Let me see if I can unmute Tembula. Tembula, you're unmuted. You can also
Okay,
ask a question.
I've got it on incidental findings. So your question, Temba, is, are you compelled to inform patients on incidental findings? So I think that's a really good question and an interesting one. It also depends on what you're doing and what setting you're doing it in. So for example, in the clinical setting, you know, if we are doing, let's say, a gene panel for inherited cancers, and we strongly suspect a patient has inherited breast and ovarian cancer syndrome, and you happen to do a genetic panel that actually they now land up having Lynch syndrome, which is a different inherited cancer syndrome, then yes, you are compelled to inform them of this, because obviously this has got genetic implications for them and for their family members. But that's where the informed consent comes in. Do they know what they're actually being tested for? Do they know that there's a possibility of incidental findings? And again, it depends on what's important to convey and what's not. So that's where, you know, it becomes quite difficult sometimes for researchers to make that call. Is this an important finding to report to patients? Has it got clinical significance? Is there something that can be done? And those are the kind of things one needs to really think about in terms of incidental findings. So informed consent is really important to make sure your patients are aware that there could be incidental findings that might come and that they need to be prepared for that, especially those that have clinical significance. I can see, I just wanted to let you know, and I have, you know, made a comment that there are medical geneticists. So I've spoken about medical doctors that have specialized in genetics. They are medical geneticists, and we work closely with them. So our team here comprised of genetic counselors and medical geneticists. And so I think I mentioned earlier in my talk that medical geneticists often see children with dysmorphic features or developmental delay where diagnosis is not necessarily known yet. And their role is to examine and assess and put all the features together to see if they can diagnose a genetic condition. So, and genetic counselors obviously also do genetic counselling. They don't have an MSc Med in genetic counselling. They have, at least in South Africa, they have an M.Med, a Master of Medicine in Medical Genetics, but part of their training is also being taught how to talk to patients, how to counsel patients, and so forth. I think it's important for everyone to know that there are various clinical genetic specialists.
So I'm just reading. Emmanuel has asked, how well would you respond to a person with family history of breast cancer about their lifetime risk of acquiring cancer?
So that would, you need to have a look at their family history. What kind of cancers are in their family? Does it look like it's a dominant cancer? Who in the family related to the patient has had breast cancer? Because their risk of having the gene could be 50% if one of their parents has got it. So it depends on what cancer syndrome you're dealing with. The lifetime risk of inherited breast cancer for HBOCS, which is hereditary breast and ovarian cancer syndrome, for example, is 80%. But that's if they have a genetic mutation. So you really need to look at the pedigree and determine what genetic cancer syndrome does this fit with before you can advise what the patient's genetic risk is and then their risk of getting cancer based on their genetic results. So that would be important to determine. There's so many inherited cancer syndromes. So, and all of them have different risks associated with the different cancers. So you'd need to get more information and work out what genetic syndrome you're dealing with. And that's where genetic counselors can assist.
Thanks, Shelley. So Paul is asking, what are some of the common causes of the change in DNA?
What are some of the common causes of the change in DNA?
Yes.
So there are mutations, and those mutations have arisen, sometimes they're de novo, they arise in the child or in the individual for the first time. Other times they're often inherited and passed on. So those, I'm really referring to monogenic conditions, causes, genetic mutations that have been present in families for a number of generations. And sometimes it can happen for the very first time and we don't understand why in a particular person. More so with autosomal dominant conditions.
And Sophia is asking, she's saying, thank you for the amazing presentation. I just wanted to find out if there are any plans to make the master's course a fully online course in the future.
So I think that's a good question. I don't think it would be a fully online course ever anywhere around in the world because you need a lot of clinical exposure. So you need to be in clinic and observing genetic counsellors and practicing doing genetic counselling under supervision. You couldn't just do this course online and then become a genetic counsellor. What we are looking at is trying to get other areas around the world and around our country to consider short courses, maybe just a brief course in basic genetics. But that does not mean that individuals would be able to call themselves a genetic counsellor. You have to have the master's degree in genetic counselling to be able to call yourself a genetic counsellor. And yeah, I think that online is a wonderful way of educating nowadays, but when you have a practical component, that's really important that you're on the ground and in the clinics. So maybe in a few years' time or in the future, we could look at possible various components that some can be done online, and then other parts of the course can be done in person and in the academic institution. Something to think about.
All right, Sophia is also asking, what are some suggestions on how to overcome the language barriers when counselling, since you mentioned some terminologies are not available in local African languages?
That's an excellent question, one we grapple with every single day of our lives. So the large majority of our genetic counsellors are English speaking, which is a problem because, we've got 11 official languages in South Africa. And so, as I said to you earlier to one of the other attendees, we have to be flexible in how we explain things. And often you align your information giving to what patients know. So you need to be adaptable. So for example, someone who builds houses and maybe has never heard of genetics before, you'd be able to explain how cells are like bricks that make up the wall. Genetic counsellors are really quite imaginative when it comes to coming up with ways and means of explaining very complex concepts. One of my students, interestingly enough, is doing a study looking at words we could use in some of our South African languages that could possibly convey genetic terminology. So he's looking at creating a South African dictionary for genetic terms, and it'll be interesting to see what he finds at the end of his research. But that is a problem that we do face on a daily basis, and I think many genetic counsellors around the world who don't necessarily speak all the languages in their country face the same thing. We need to be inventive.
And then Catherine says, how do you counsel patients who need to take home information on inherited genetic conditions that may impact family members?
Yeah, absolutely. Very good question. So we always strongly encourage patients to disclose their diagnosis or their child's diagnosis if it's got implications for other family members, for example. So if you're dealing with a couple whose baby has Down syndrome is not something that's going to affect other family members. But if you're dealing with a couple whose baby has cystic fibrosis, that means the couple's brothers and sisters could also be carriers. So we strongly advise patients to disclose this information to their families. As I said earlier, genetic conditions rarely affect the individual. They affect the whole family. And we assist with that by, one, always writing a summary letter. So often this news is really overwhelming for patients to take in all these different concepts. So we'll always write a summary letter for patients, like, thank you for coming for a consultation. This is what we discussed. This is the pattern of inheritance. This is what we need to do for the child, etc. And the other thing that we offer to do is write a cascade letter. So, dear family member, we saw a member of your family, they have a diagnosis of cystic fibrosis. You could be at risk of being a carrier. We would strongly advise that you contact your nearest genetic center. So we facilitate that.
And Bunny is saying, thanks for the webinar and a brilliant presentation, which is very motivating. Grace says, did she hear you, or to me, in fact, say about free courses? So just for Grace, it's the Welcome Genome campus that is offering a free genetic counselling short course.
Yes.
So you should, yes, just go on the Genome campus's website.
Yeah, the Welcome Genome campus in Cambridge. It's a free online course. And the purpose of that course was to educate the general public about what genetic counselling is and what kind of cases we see. It's a really nice course to do. So I'd strongly advise people to have a look at that.
And then Bunny says again, do we need to have a deep understanding of all genetic conditions or just common genetic conditions to be a complete genetic counsellor?
So with you know, with the advancement in social media and technology and, you know, different encyclopedias and genetic textbooks and all of that can be at our fingertips. So you need to have a really good understanding of most genetic conditions, but obviously there's some incredibly rare genetic conditions that, you know, even in I've been practicing for more than 10 years, I've never seen. So it's really important to have an understanding of the basics and the inheritance patterns, but you're never going to know every single genetic condition there is out there. So in our training, we expose our students to the conditions they're most likely to see. So I'll just give you a few examples. They need to have a really good understanding of Down syndrome. We see a lot of Down syndrome. The different trisomies, 18 and 13, hemophilia, cystic fibrosis, albinism. We see a lot of albinism in our country. Common conditions, Huntington's disease, fairly common. And the list goes on. But obviously there's always going to be genetic conditions that, you know, maybe you see once in your lifetime. So you're not expected to know everything. And also your experience, and that's why I said genetic counselors need to be lifelong learners. You learn every single day. There are new genetic conditions being discovered all the time. So you need to be able to keep up with that. So to answer your question, no one can actually retain information on every single genetic condition out there, and also there are many genetic conditions that are yet to be discovered. But if you have the basic principles and you have an understanding of the basics and you understand the common conditions, you should be able to manage any case that walks into your clinic.
All right. Shirley, the next question, I think you might have answered it already. Kostembele wants to know, how do you handle disclosing incidental findings that you are aware that can be transmitted to the next generation, yet the participant refused to involve family members? So I think you mentioned about the letters.
No, so I was talking about the we're talking about incidental findings, but also the question was how do you inform other family members? So that's a tricky one, you know. The genetic counsellors, we can't just phone up a family member and say, oh, by the way, your sister has had a child with cystic fibrosis. I mean, that would be unethical. And remember, we have to abide by confidentiality and respect confidentiality in our sessions. You would need to strongly encourage a patient to disclose the information. Unfortunately, if they choose not to, there isn't a lot that you can do about it from an ethical perspective, because you can't break confidentiality and go and contact the family member and say, do you know this? So it's a tough one that I've very, very rarely ever had to deal with. Most of my patients have a good understanding, and I think that's also the importance to drive home here, is to educate them on why it's important to disclose this information and who else in the family this might affect and what will happen if they have a baby with the same condition. So sometimes patients just need to have a little bit more time spent with them and a lot of counselling around coming to terms with the diagnosis before they're actually able to then say, okay, I understand and I'm going to share this with other people.
Okay. And Catherine is just saying, do you think it's mandatory for genetic research projects to have a genetic counsellor available for patients?
So Catherine, I'd love to say yes. I think genetic counsellors can help all genetic research projects, but the reality is there aren't enough of us. I mean, if you look at South Africa, we've got less than 50. So we've got research projects all around Africa, all around the world, as you know. I think that in an ideal situation, it would be wonderful if all genetic projects had a genetic counsellor on board, or at least had networks with genetic counsellors. So maybe that's something to think about. Maybe they don't have their own genetic counsellor, but they've got a network where they can contact a genetic counsellor if they need assistance, or if they need help in explaining something to participants or to patients, to be able to talk to a genetic counsellor about how best shall I do this. So I think we need to be realistic. And in the ideal world, as I say, it would be wonderful, but realistically, there just aren't enough of us yet. We need to have more jobs available. We need to start following what the USA is doing. They actually can't keep up with the demand of genetic counsellors. I was talking to a graduate there the other day who said before the end of their second year of their master's, every genetic counsellor in America, every genetic counselling student has been given 3 job offers. So that's the way the developed world is moving, and we can't expect the same from our situation, but something to think about.
Actually, we're running out of time now, so quickly. Judith says, thank you for the presentation, and she knows that in the region, the genetic can be found largely in SA. Any advice for institutions that may want to start a genetic counselling program, particularly regarding how to get the program and the practice of their graduate license?
Yes, so actually we are, we have been in touch with colleagues in Africa about them setting up a genetic counselling program themselves. I think what you need to do is, make contact with the programs that are already set up. So for example, such as myself at WITS, and obviously the course coordinator at UCT, where we could guide you about what a program actually entails, what are the components. The other thing that's really important is for teaching genetic counselling students, you have to have genetic counsellors. So again, this would require a partnership, maybe between that university and ours, or UCT, where we could give input and be involved in training. You need medical geneticists as well to teach. You can't run a genetic counselling program without doctors trained in medical genetics. So there are a lot of components, but certainly something we need to start thinking about and start getting this profession more into Africa. So I'm happy to always discuss options and possibilities with any of you. So something, if that is something that you're interested in, you're more than welcome to contact me.
So Catherine is also asking an interesting question. Do genetic counsellors keep in touch with the families with rare genetic conditions to learn how it impacts individuals?
So yes, and remember, most genetic conditions actually are what we classify as rare. They're individually rare but collectively common. So if I see a patient, I might contact them in a year's time to see how they're doing, but also patients tend to stay in contact with us. So just to give you an example, in our department, we never ever discard genetic files. You are legally obliged to keep them forever, because genetic conditions are in families forever. So we've got files that date back to 1960. So even before the genetic counselling program started, we've got the genetic files. And now we've been seeing families that have come back to genetics after 30, 40 years, and staying in touch. New generation needs genetic testing, wants to find out what was done before. So yes, absolutely, we stay in touch with our families. And again, it depends on the case. Sometimes it's a once-off session. We don't tend to see patients over and over again for counselling per se. It's not like psychotherapy. So we would see them for a consultation. We might see them for a follow-up. If we take blood for genetic testing, we might see them again for a result-giving session. But ultimately, the patients do stay in touch with us.
All right, Grace, perhaps I could answer your question about scholarships. I'm not sure if there's specific scholarships for genetic counselling, but with the universities currently offering them in South Africa, you should certainly check in with the university websites about scholarships for any of their degree programs. Then Tembele just wanted to say, you're saying it's an MSc, but is it really necessary to also do the sciences done by medical practitioners? I'm not sure if that is part of the curriculum for this MSc.
I'm not sure I understand the question. So it's an MSc Med, a Master of Science in Medicine in Genetic Counselling. And most people come in with a science background. You have to have a basic understanding of genetics. You can learn the counselling skills, But to be able to now have to counsel on complex conditions and not understand meiosis and mitosis and DNA and RNA is really problematic. So individuals need to come in from a science background, or if they haven't come in from a science background, certainly in our course, we ask them to write an entrance exam. So if they've got a nursing background or a BA honors degree in psychology, they need to be able to have a basic understanding of genetics in order to be able to cope with this. So they have to have science, and also part of the coursework is understanding basic science. So in our first module, we'll teach individuals about basic laboratory techniques, PCR, and the different tests, karyotyping, aneuploidy. You have to understand that science in order to be able to explain that to your patients.
Right. Thank you so much, Shelley. I'm going to have to leave it there. There was only a few more questions, but perhaps they can contact you via email. Are you happy to share your email address if they have any further
Absolutely,
questions?
very welcome to share my email address. I'm more than happy to answer anyone's questions.
All right, because that is all we have time for today. We're running over time.
Thank you.
But thank you so much, and thank you all for the wonderful questions that came in.
Thank you. Bye.
Hi, Rolanda.
Yes, Emmanuel.
Yes. Yes. Hi, Rolanda. This is Emmanuel.
Yes, I can hear you.
I want to thank Shelley for the presentation. It has been a wonderful presentation. I think members have benefited. More so the Ugandans who have genetic studies where it is a requirement to have a training in genetic counseling, at least a baseline training. Then I also want to thank the coordinators who made it to the meeting. I hope they have benefited, and hopefully we shall meet in Ghana. Thank you very much.
Thank you, Emmanuel. Thanks, everyone. Have a pleasant day further.
Thank you, Rolanda. But is it possible that we are going to have some presentation so that we can continue reading?
Yes, so we can share the presentation, this presentation.
Okay. Okay, thank you.
All right.
Bye-bye.
Thank you. Bye.
Thank you. Bye.